everybody should know it, that about 15-20% of ischemic stroke is caused by carotid artery disease, occlusive disease, stenosis or occlusion. Unfortunately, we don't have too much to do if the artery is already occluded and we are out of the first day, because during the first day we can make mechanical thrombectomy in a narrower time window. We can perform IV thrombolysis, but after the first day, our activity could be restricted only desobliteration, including stent or endarterectomy. And there are many questions. Who is the optimal candidate? And when is the optimal time? As for the present and valid guidelines, everybody knows that within 2 weeks, so the early phase after a mild ischemic stroke, not a serious one, a mild ischemic stroke or TIA, we have to make a desobliteration with stent or with endarterectomy. There are different guidelines, but we can conclude that the age is one of the important criteria, and sometimes what is the type of the stenosis caused by, for example, radiation stenosis and rest stenosis after endarterectomy. If by these patients we don't have too much hesitation, we have to continue, for example, only by stent. But is there only the MRI, only the carotid CT angio, and only the severity of stenosis, the only criteria or only the most important criteria for this decision making? I don't think so. The ultrasound can give insight into the plaque structure. Under simple CT angio, you can see if the plaque is calcified or non-calcified, but you don't have any important precise information about the density, echolucency, or echo reflection of the plaque. And these features are connected, the complication associated with stent and endarterectomy. On the other hand, it has been proven by different kinds of trials that endarterectomy has less complication rate compared with stent. Embolization rate is less in case of endarterectomy, for example. So during in my presentation, I should like to prove that the ultrasound investigation before intervention, before a decision, stent, endarterectomy, ultrasound should be performed, and the ultrasound can have us to select those patients who are appropriate for stent or for endarterectomy. And during my lecture, I should like to collect those important informations and papers from the medical literature that could support my hypothesis. Gray median scale is one of the most important parameters, as for my personal opinion, and I should like to persuade the people sitting in the room or in front of the screen that the gray scale median can be useful to select if a plaque is unstable or stable. The lower this value, the higher the possibility that complication or stroke will happen. So I should like to prove that these patients who have low gray scale median, they should be treated not with stent, but with the endarterectomy, or if you are hesitant to make any, either none of the two interventions, conservative therapy or invasive intervention, perhaps you can stay by the conservative therapy and you don't do perhaps none of them, neither stent or endarterectomy. So this is the main goal of my lecture.